Let's do it. Let's do it, folks. Let's just get everything checked out, and then after we get everything checked out, we will start the show, But let's just make sure. Okay, that looks good. That makes sense. That's sounding good. We just share this on ye olde Twitter, and then we will get the show started, and everything should be hunky-dory, as they say. So give me just a second, and we will get going. Okay, I think, if I'm not mistaken, we are live and everything is good to go. Well, good afternoon, everyone. Welcome to UnShrink Me. My name is Dr. Patrick Lockwood. This is my weekly podcast on psychiatry, psychology, mental health, treatment, and various similar related topics. Welcome to UnShrink Me. This is a weekly podcast dedicated to you, the consumer, and the viewer. This is about people who need help in various ways, be they more formal or informal. And the goal of this podcast, just so everyone is perfectly clear, is not to demonize people or the profession itself. This is an optimistic podcast about what could be better and is getting better and could be improved. And so this is a podcast for the consumers, for society in general, and for the folks that are professionals who watch and listen. Please listen with an open mind, because the goal is to help improve the practice of psychology and psychotherapy across different types of populations and for different types of people by being critical of the malarkey that's already out there and potentially maybe hurting people. This podcast happens every Saturday in the afternoon, so thank you all for showing up and taking time out of your weekend to come chat and hang out and ask questions and be part of. As always, this podcast is not NOT, sponsored by Celsius, but I do happen to think it's great. So away we go. We have so many interesting topics today. We're going to start out with a brief discussion of AI and the ongoing problems with AI and mental health. And then we'll move on and we will discuss a couple of posts about the profession itself and how professionals respond and treat themselves and carry themselves online and in real life. And then we will kind of wrap this up with a discussion, hopefully, about what is happening specifically with therapy and how to deal with treatment versus healing versus therapy, because these terms are used interchangeably, and sometimes people need a little clarity on what exactly people mean by these terms. So that's the basic agenda for today. I hope that it is at least interesting, if not stimulating in some way. Please like, share, and subscribe. Any and all help in the word out about this podcast would be awesome, because, again, my goal is just to protect the consumers from the profession, because a bunch of well-meaning people can easily hurt patients for no good reason, for good reason, or for pure ignorance. And my goal is just to help limit that if possible. So, point number one today, we're going to talk about AI, chatbots, and therapy. And so here is point number one. Here's post number one. I just found this morning. And I don't know this person, so we will see how it goes. Okay. So earlier today, about 6 hours ago, psychologist, Louisa Jorovsky, her handle is at LuizaJraov, SKY, a little phonetic spelling. And she said, "Dear AI companies," this is an exact quote, "an AI chatbot must never pretend it's not an AI chatbot. There is no level of creative or satirical freedom that should allow that. By the way, Not only should this be legally prohibited, but it should be a screening test for stricter regulatory scrutiny. AI regulation is still far away from what it should be, but we'll get there. So she posted a screenshot of some chatbot that calls itself a psychologist. And there's actually a picture of a psychologist or something like that there. And the chatbot's name, if you ever get a chance to take a look at this tweet I posted just now, the AI chatbot's name is psychologist. And so when you use an AI chatbot, usually it's like the AI's name and then your thought bubble, like you were texting with your name and the AI's name and your name. And so it says psychologist. It's in the very first line of dialogue when you enter this AI chatbot is, hello, I'm a psychologist. What brings you here today? And no, this is not a psychologist. There's no AI that is a psychologist because a psychologist is a clinical and legal term. It's a professional term. It's a term of art and science. You have to have a certain degree with a certain kind of training and a certain kind of license to be a psychologist, right? So a clinical psychologist is a person with a doctorate degree in clinical psychology, usually, who has had a number of different types of courses that fit for clinical psychology training with 3,000 hours of licensed supervised experience or pre-licensure supervised experience and any other postgraduate training. And so you've got all these years of training, all these years of education and licensure that makes you specifically a psychologist. A psychologist is not anyone with a PhD. A psychologist is not anyone with a license. There are lots of licensed professionals that only have a master's degree, for instance. And so this AI chatbot calling itself a psychologist is wildly unethical, and it's just not okay in any way, shape, or form at all. So just beware that there are chatbots out there that have different types of monikers. They have names and handles like I'm your therapist or I'm your psychologist, and that's absolutely absurd and not okay because it's going to mislead people, especially vulnerable people, people who are mentally ill, people who are undereducated about what these things are, people with low social skills. So there's a lot of people who are going to be hurt by this, and this is a huge problem. So, dear everyone, if your chatbot, if your large language model says, I'm a psychologist, or I'm a therapist, or I'm a clinician, or uses some word like that, that is never okay. That is not okay. And you should run screaming from that because maybe it's built with data that's good or something, but it's misleading you about what it is and what it can do. And that's terrible and bad for everyone. So please run screaming from anything that says, I'm a psychologist, if it's an AI or a chatbot. So, dear Lord, whatever company this is, what is wrong with you? I mean, it's absurd that this exists in the first place. Yeah, it's not okay. Like there's Replica, Captera, there's AI mental health chat for adults, there's Therapeak, I guess. Chat with psychologist, character.ai. I just looked up right now that says, hello, I'm a psychologist. What brings you on today? Well, you can't really see it, but it's like, it's absurd. It literally says, hello, what brings you on today? I'm a psychologist. That's crazy. This is crazy. This is wildly unethical. I'm just going to repost this real quick. This is wildly unethical. Because it's not a psychologist. It's some algorithm that may be filled with the DSM criteria, may be filled with prompts for empathy and empathizing and all this stuff, but it's not a psychologist. There's no AI, there's no large language model that's been created that performs at the level of a licensed clinician, especially a psychologist. So, nope, not okay, terrible, dangerous, not okay. So, dear consumers, dear family and friends of people who have mental health problems, If your loved one is using AI to deal with its loneliness, to deal with their mental health issues, please do everything you can to get them away from that because it's bad, it's dangerous, it can hurt vulnerable people. It can corrupt them. It can teach them untrue things about themselves. And in some cases, as we've talked about before on the podcast, it can convince them that taking their life is a correct choice. So please do not allow people you care about to use AI. Ask them if they're using AI. It's not okay. It's bad. It's terrible for mental health. All right. So, topic number 1, done. Donezo. All right, topic number 2. Clerks versus healers. So I want to talk about this because this is important, and I really want people to understand what kind of therapy they're getting. So I'm going to retweet something real quick from someone named Nick Tabor. His handle is at NICKTABER. And here we go. Nick is one of those very online skeptics or critics of the mental health and psychiatry industry, and I think that's great, and I have no problem with that. I think Nick is a little more measured than other people that I've talked about online and that we've talked about here on the podcast. So let's be clear about, what he actually said and why this is relevant. Nick said about 6 days ago, and I'm going to just read this word for word. He said, many mental health professionals are effectively clerks rather than healers. But if you read history, you'll know that clerks are perfectly capable of committing atrocities. And so I'm chuckling because he's correct, and I think he's absolutely correct about the clerks in clinical psychology and psychiatry as well. So let's be real, folks. Not everyone who has a license or a credential or whatever, not everyone who calls himself counselor or therapist or doctor actually knows what they're doing. I think that's an unevocative or unequivocal statement. I think that makes sense. So there are people who are just flat out incompetent that exist in the profession. But because they're smart enough to pass their licensure exam and, do the parrot thing and get past supervision, they will go out there and practice. But that's not the group of people I'm talking about. There's a separate group of people who are licensed professionals who do this work for a living, who are effectively clerks, as Nick Tabor just said. And I want to talk about this because I think it's very, very, very important. Jake, who just chimed in here on the chat, good to see you, Jake, said, I was shocked at how many do not know what they are doing. Yeah, it's initially very shocking, but there's a lot of people who have a license who just have no clue what they're doing, which is interesting because it's a rather rigorous process for many people to get licensed. You have to go to all this school. You have to do 3,000 hours of supervised, clinical practice. Now, that doesn't mean that you're going to get good supervision and that you're going to do all those 3,000 hours well. There's a lot of scammy people who will just sign off on your hours. As a supervisor, I don't just sign off on people's hours. I talk to people. I meet with them multiple times a week. We talk regularly. I look over their notes thoroughly. I think about what they're going through and they're doing. And we have discussions about their countertransference and their clinical skills. It's a problem when you have lazy supervisors, and there are many lazy supervisors, and that's a different topic for a different day. But I want to get back to this. Yes, Jake, it's extremely shocking how many don't know what they're doing. There are so many incompetent or mediocre people out there in the field, so be careful. So let's talk about clerks versus healers, right? So Nick, in his post 6 days ago, talked about the difference between clerks and healers. And then he went on to say how clerks are a big part of various types of human atrocities in history, including in military atrocities and the Holocaust and all these terrible things. It's abundantly clear that there were a lot of middlemen, a lot of manager, bureaucrat types who kind of helped the machine run, and atrocities were committed because the machine was running so effectively because of those clerks. And so the same thing is true in the mental health and drug treatment industries. There are many clerks who are just helping the machine run. And even the practitioners themselves, the therapists themselves, are clerks in many cases. So some of you might be wondering, how would I identify the differences between a clerk therapist and a healer therapist? Well, I think it's perfectly fair to start this with at least a definition, right? So what precisely is a clerk in the general sense? So a clerk can be someone who performs basic record keeping and office tasks. They could be a sales assistant, like they're selling you things. And so let's take those two broad categories of behaviors. A clerk is a person who conducts record keeping and general office tasks and who often sells things in a retail setting. And so it might sound weird to say this, but in reality, therapy, clinical psychology, psychiatry, these are businesses where you do have to sell things. You have to sell your services. If you're a therapist who has a private practice, you have to sell things, right? That's not a weird statement. And so I think it's important to be clear that some clinicians are very wrapped up in the clerk life that can be therapy, right? So some clinical psychologists, some psychiatrists, some social workers, etc., are merely clerks. In fact, I'm willing to argue that most social workers and case managers really are just clerks. They're just shuffling paperwork and checking boxes to make sure linkages of services happen. And that's not really therapy per se. They're not trying to heal a thing or solve a clinical problem. They're trying to solve logistical problems, right? So solving logistical problems might be one symptom of having a clerk therapist. Is your therapist interested, by the way, in solving logistical problems? Are they helping you solve logistical problems? Or are they helping you look at psychological processes and emotional issues with the intent on resolving those issues? Right? Those are two different types of people. Another classic symptom of a clerk therapist is where the focus of their clinical experience with you is on checking the boxes they have to check in order to do a protocol or something of that nature. And checking those boxes so that you can bill correctly or whatever it is not really healing anything, usually. It's usually just helping you accomplish your goals so that you can fill out the correct documentation. So that's a clerk therapist versus a healing therapist in that regard. Jonathan Cogburn just chimed in here and he said, working in community mental health for 2 years, we got regular training on how to correctly fill out our routine paperwork. To ensure billable units, we got a single half-day training on techniques. Yeah, so again, community mental health is almost uniquely all clerk therapy and not really healing therapy for sure. We have a new chatter. Who is this? Philigan B, is that who this is? Hello, hola. Jonathan says, most of my coworkers had a bachelor's in non-psych fields, education, criminal justice, etc. Yeah, and those are going to be clerk clinicians. They're not going to be anything other than clerks usually. He says, I am me. I me. Good. I'm glad you're you. I'm glad you're here. So we're talking about the difference between clerk clinicians and healing clinicians. And this is prompted by one of Nick Tabor's posts on Twitter. Oh, hey, Phil. Good to see you, Phil. Excuse me. So, hoorah. So, what is the difference between a clerk therapist and a healing therapist? And so far we've identified two different traits of a clerk therapist. They're interested in checking boxes and filling out paperwork. Another classic difference is they're interested in selling you on ideas. If your therapist is trying to convince you of something, if they're trying to convince you of what your trauma is, or they're trying to convince you of a technique, if they're selling you something, then that is not a healing therapy. That's a clerk therapist. So that's a third symptom of a clerk therapist. I think another classic symptom of a clerk therapist is someone who is interested in formalities above and beyond the clinical relationship with you, right? So many clinicians, sometimes intentionally, sometimes unintentionally, very, very, very unconsciously will care about formalities of the session over and above the quality of the relationship. So, for instance, many clinicians, especially newer clinicians, are very anxious about, helping people. And so because they're so anxious, they'll stick rigidly to like a protocol, like a CBT protocol or whatever it is. And so sticking rigidly to the protocol is really more about the clinician's insecurities and also about their inability to trust in the process of having a clinical relationship. And so there's some importance to structure in a therapeutic frame, as the analysts would have you believe. But being rigid about the frame, having a fear based relationship with the structure of things, is also a sign that you have a clerk therapist because they're not really interested in the relationship with you. Now, I want to talk about what it means to be a healer real quick because this phrase really bugs me for so many practical reasons. So, healing is one of those very strange and ambiguous words. It's a word that doesn't even have, I think, a great definition for clinical psychology and psychiatry. So, textbook definition is healing is the process of restoring health or wholeness, whether physical or emotional. Health or wholeness. Okay. So what is health? Nobody knows what health is. Like literally nobody can define mental health. So who the fuck knows what mental health actually is? Honestly. So what is mental health healing? Like who honestly knows? Right? Darren says, interesting chat. Well, welcome, Darren. Glad you're here. I know you're staying up late for this. Thank you. So the process of making or becoming sound or healthy again, right? So what does it mean for something to be sound? It means that it is structurally complete and can withstand, can be resilient to the various stressors that are normal for that system or that issue or that skin or that object. And so I think good psychotherapy is healing, right? A healing therapist is someone who is helping you become sound. They're helping you become complete in the sense that, let's just say you have major depressive disorder as the easy example. If you are sound when you have major depressive disorder, you might have a variety of self-defeating thoughts that make you unnecessarily fragile in the world. For instance, a lot of people with major depressive disorder will have what are called core negative beliefs about themselves and the world, such as, I will never be loved, or I will never be okay, or I will never feel good ever again. And those core negative beliefs can leave people with cynicism, low mood, and a sense of learned helplessness that keeps them fragile, that keeps them unnecessarily sensitive to punishing circumstances or stressful circumstances, because clinical depression appears to be a disease that responds to stress adversely. And so part of what you do in good therapy is you help people with these core negative beliefs if you're a cognitive behavioral person so that they can become more sound. If we can help eliminate or alter these core negative beliefs by doing talk therapy and behavioral therapy, you can help someone become more resilient to stressors and anything that boosts your cortisol, for instance. And so a healing therapist is less interested in the formalities of things, and they're more interested in the process of healing. They're interested in the process of you becoming more sound. They're interested in the process of you becoming more whole. So, for instance, a lot of people see themselves as unworthy or incomplete as people. I will never be lovable until I achieve this thing, for instance. And so that's an incompleteness. And so good psychotherapy helps you see the irrationality of that thought process that you are never going to be complete unless, right? And that is something that's really hard for people to do in therapy. And it's easier to just rely on the check boxes of, did I teach you that coping skill? Because if I taught you that coping skill, then I did my job for today and I get a cookie, which is bullshit, by the way. Darren McGee says, I'd suggest it's feeling okay and functioning well. I think that's not a bad start for the concept of healing. I just think it's incomplete, right? Because becoming sound, as the technical definition says, is a little more complicated than just merely, just merely like functioning well. Functioning well and resilient to stress, I think, is a big part of it. Someone just asked, do you have patients run the sessions or do you direct them, or does it depend? Well, it should always depend, and it should always be a reciprocal relationship. So the type of therapy will be different for different people depending upon what they need, Jake. So yeah, it's an it depends question, sir. Okay. So again, back to Nick's post. Many mental health professionals are effectively clerks rather than healers. And so I really encourage you to be clear. If you're not doing well, if you're really, really struggling, you might benefit from a clerk therapist because that clerk, that case manager, that LCSW usually, will be helpful in helping you link to services. They'll make sure you get to your psychiatry appointment. They'll make sure that they, achieve some practical, concrete goals. Like they'll make sure you get out of bed. They'll make sure you do all these things, right? So they'll do practical things with you. And that's useful for people who maybe are very, very severely limited by their very severe illness, for instance. That's not unusual. And so there might even be a case for clerk therapists in some narrow circumstance. However, the folks that you would call healers are also very important, but also I want to be clear that many people who think of themselves as healers online are narcissists. There are many people who are very loud and very clear about how quote unquote effective they are online. And sometimes they do it very overtly, right? So there's all these people with Instagram accounts who are like gurus and coaches and wellness influencers. And those people you should basically completely ignore altogether, because essentially what they're trying to do is they're trying to sell you on their services by talking about how awesome they are and how good they are at their job, which should concern you. It should really concern you, because no professional worth their salt should be speaking publicly all the time about how awesome they are. Like on this podcast, there's hours and hours of me talking on this podcast, and you've never once heard me say how amazing I am as a clinician. In fact, I basically said the opposite, which is I don't even like therapy. I don't even like doing therapy. I'll certainly do it with some people if I have to. I think I enjoy clinical supervision and consultation way more than therapy I ever will. I think a pretty good educator. I have a lot of fun as an educator, as a professor, but I don't like therapy. I guess, good at it in some circumstances, but I don't even think like that because it's such a nonsense way of thinking about the process of healing. The process of healing is not something you can be amazing at. That's bullshit. Medicine is a practice. Psychotherapy is a practice. It's the practice of medicine. It's the practice of being a clinical psychologist. So the practice means that you're not perfect, means that you're not amazing. It means that you're always improving. You're always looking at what you're doing and how could it be better. Where did I show up wrong here? Where did I use the wrong language? Where is my countertransference at play? All these kinds of things. People who talk about themselves as if they're amazing are a huge problem. But they're convincing, right? They're convincing because they sound like most gurus sound. So be careful of the so-called healers that you follow online, including myself, right? Everyone should be looked at with at least a couple of grains of salt, because you never know what people's motivations actually are, for sure. So healing therapists, probably preferable for most people with most mental health problems. Clerks, definitely, watch out for them. They're probably not going to help you in the way that you're hoping to be helped. So I want to talk about this post, and I don't want it to seem too tangential or esoteric, but I think it relates specifically to what we were just talking about. So I don't know this person at all, and I'm just going to repost it real quick. So if you're on Twitter, find me at Alobha, Alobha, Patrick. And you can see the post that I'm discussing on this podcast. Okay, so David Robbins, and his handle is at David P. Robbins, David P. Robbins. So here's what he said. He said this on November 10th. He said the knowledge/experience gap between a good therapist or psychologist or psychiatrist and the average person who has no training is a chasm equal or greater in size to the Grand Canyon. The knowledge gap between a mental health professional who has zero experience working in acute care, which I'll define later, and those who have is also a disturbingly large knowledge experience gap. People have literally no idea. So I want to talk about this. And David, thank you so much for this post. So I want everyone to understand that there are a lot of anti-psychology and anti-psychiatry cranks online. People who are not even reasonably skeptical, they're unreasonably skeptical. I consider myself reasonably critical, and I try very hard to be clear and precise in my criticisms and not use unnecessarily evocative language when I'm being critical. And so what David is saying here, I think, is extremely important because a lot of the criticism about does therapy even work, why do people even do it, is based on this straw man argument of like, this is something I think Justin Garson does all the time on Twitter. A lot of these people equate serious mental health problems to just problems of living. And I think all of us have had the experience of being extremely sad because we just went through a loss, or extremely anxious because we have a giant work thing coming up, or extremely angry because our needs weren't getting met in a reliable way by someone important in our life. And so all these feelings I just described are perfectly ordinary in context in limited doses. Most people don't live with pervasive anger all day. Most people don't live with pervasive sadness all day. Most people don't live with excessive anxiety all day. That's statistically extremely rare. Likewise, psychosis, mania, depression, these are all statistically very rare things. Sadness, ordinary sadness, is not rare at all. In fact, it's ordinary. It happens all the time. You can listen to sad music and be sad. I did that this morning, and it was a lovely experience. And I'm so grateful I got to do that because it reminds me of important emotional experiences. I've also listened to super happy music today, and that changed my mood, and that was awesome too. And so it's really important to be clear that there are so many straw men on the pro-therapy and the anti-therapy movements, right? So the pro-therapy people are like, oh my God, mental illness is a house fire that has to be treated with a giant squirt or like super soaker or fire hose because it's a house fire and people are dying in droves and it's a terrible tragedy. That's the pro-therapy thing, and the straw man is it's a giant catastrophe and it's an urgent crisis. Not real, not true. The other straw man is from the anti-psychiatry, anti-therapy people who are like, there's no such thing as mental illness. It's just ordinary problems of living that are just a little out of control. And that's such bullshit. And that's why I'm bringing up this David Robbins post. So he said, the knowledge and experience gap between people who are serious professionals and regular people who've never had any training or experience is a chasm the size of the Grand Canyon. And for people who've worked in acute care, what he means by acute care is a psychiatric hospital, an urgent care, a regular hospital with an ER, or an intensive treatment center, like a seriously intensive drug rehab or whatever. Like those settings are nothing like outpatient therapy. So working in acute settings with people who are seriously mentally ill and on the verge of dying, on the verge of overdosing and dying, on the verge of dying by suicide, on the verge of death by cop because they're schizophrenic or whatever and aggressive, like whatever it is, like that group of people, treating those very seriously ill people, life-threateningly ill people, is nothing like going to your private practice therapist and whining about your childhood twice a week or once a week. That's not remotely in the same zip code or same universe as the same problem. Now, if you're going to your private practice therapist once a week and you're pissed off about your childhood, that's probably the perfect place to be pissed off about your childhood. Because probably that therapist can help you resolve your attachment stuff, your resentment towards your dad or your mom or whatever it is. And that's the place to do that. But thinking that that experience clinically and psychiatrically is the same thing as being in an actual psych hospital is absurd. And so let me tell everyone abundantly clearly that there is a world of difference between acute care, psychiatric, and clinical psychology settings versus outpatient therapy. If you go see your therapist once a week because you're angry about your childhood, you are immensely lucky in a way that you don't even understand, because you have the access to resources, you have the access to a clinician who can hopefully help you, and you're not suffering so miserably that you have to be institutionalized so you don't die. That's a drastically different experience. Darren says, the proof that the online gurus are generally fake, is that they forget that the client is the expert on themselves. Yeah. And I think that the gurus also forget that life is extremely complicated and no simple idea is going to fix it. You cannot cold plunge away your depression. You cannot sauna away your anxiety. It doesn't work. There are no simple answers to actual mental illnesses. So, so I want everyone to understand that there are acute care settings and then there are outpatient care settings. So outpatient just means like once a week therapy, basically, essentially. It could be more intensely than that, but usually it's about that intense. And so the people suffering in the outpatient level of care are not remotely the same as the people in the acute psychiatric setting or the urgent care or psychiatric urgent care or the psych hospital or the ER who just, overdosed. Like those are not the same person. So please be clear that serious chronic mental illnesses exist, and the way that those are treated and managed are not remotely the same thing as treating and managing something at an outpatient level of care. It's not the same problem. It's not the same set of approaches, and you cannot treat those people the same and think they're the same. And a lot of people online who are anti-psychiatry think, well, there's no such thing as mental illness, but if you've ever spent time in an actual psychiatric ward, you'd see people who are literally out of their minds. Literally, not metaphorically. It's not a social construct. They're out of their minds. Career Flex, my buddy Jake says, sir, what of the pop culture focus on autism and ADHD as a unifying theory of everything? I don't know. That's a very interesting question because I think that there was another post I saw on Twitter a while ago that said that a lot of what went wrong in Western society is where clinical diagnoses became identities. And that's not true, right? Like a lot of things that people think are identities are not identities, right? So I think it's never a great idea to identify with an illness. I can't imagine someone identifying with their cancer or their diabetes. Just like, why would you identify with your chlamydia or your gonorrhea? I don't see that being useful. Some illnesses are chronic. Some illnesses are temporary. Some illnesses are easily treatable. Some illnesses are difficult to treat. Some illnesses are terminal. Identifying with any illness makes basically literally no sense to me in any way, shape, or form. And so I think identifying with your illness is a very bad idea. Even for folks with personality disorders where your disorder literally has to do with your identity, I still think it's not a great practical choice. Because when you choose to identify with your illness, usually what you're doing is you're changing your perception of how reality should work, right? So ADHD and autism, as the two examples you gave, right? The people that I know on the spectrum, including people in my family, I don't think voluntarily identify as a person with autism or an autistic person. I don't know how useful that is. And I think that the people that I know professionally and personally that choose to identify with their differences, I think they're making it meaningful in a way that maybe is not so useful. Like they're making it bigger than it might need to be. So, however, if you have an extremely severe illness, then that might become your whole life for a while until you get it under control. People with very severe personality disorders, that might be their whole life until they get it under control. For instance, people with very severe PTSD, that might be their whole existence. It might color everything about their life in most hours of the day. And so I can understand why practically it would make sense to identify with your illness in those circumstances. I just don't know if it's a good sign of mental health. I don't know that that's a sign that you're functioning well as a person, that you're robust and resilient to the vicissitudes of life at that point. So for me, I think your illness is not your identity, or at least it doesn't need to be and it shouldn't be. And so if you're currently there, can we move you away from that so you can have a much more complicated and nuanced identity as a person that promotes robustness to the challenges of life as opposed to makes you fragile, right? Also, some people, not everyone, I'm going to say this as clearly as I can, some people, a segment of the population, I don't know how large a segment of the population it is, but there's a segment of the population who have a diagnosable mental illness, who use their mental illness as an excuse or a scapegoat for their behavior. This happens with PTSD sometimes. Some people with PTSD use their trauma as an excuse for their bad behavior, and that's not clinically okay. If you have serious trauma of whatever kind, and it's left you with aggression reactions, rage responses, whatever the behavior, it is your responsibility to take ownership of those experiences, find ways to mitigate those rage responses so that you can live a more functional life. We can certainly be compassionate for people who have a diagnosable mental illness like PTSD, but just because you have trauma gives you no excuse to be a shitty person. And so it's very important that compassion is not an excuse. Compassion is an understanding and a sympathy for people, but not an excuse for behavior that's counterproductive for your personal well-being and the well-being of the world around you. For instance, I've worked in Rehabistan for most of my career, and I've never in my 15 years of being in the industry, before grad school, during grad school, and after grad school, never once have I said, oh, it's okay that your drug use has affected the world around you. It's okay that you're self-destructive. I've never said it's okay, because it's not okay. It's a disease. A real addiction is a disease, and it's a life-threatening disease, and it's a tragic disease. That doesn't mean that it's an excuse for terrible behavior. And so that terrible maladaptive behavior that's going to harm you, there is no excuse for it. There's only an explanation. And the explanation is you're not doing everything you need to do to manage your illness. Just like if you had diabetes and there was something you could do to manage your diabetes better, it's your responsibility to do something about that. And so it's very important that A, you don't really identify with your illness, and B, you never use your illness as an excuse for your behavior. You can try to explain yourself. Some people do need to explain themselves and be clear about what is going on and the hard time that they're having. That's different than saying, I have no responsibility for my behavior just because I'm mentally ill. Having compassion for people is not the same thing as excusing their behavior. He says, but the internet therapist tells me that enabling horrible behavior due to mental anguish is empathetic and being a good person. The hell it is. The hell it is. And, listen, this is complicated, right? Because some people are so out of their mind that they're having a hard time managing themselves. There are people who are so floridly psychotic that they can't actually take care of themselves, right? They're literally unable to take care of themselves, which means that the whole personal responsibility spiel I just gave goes right out the window. Because if you're floridly psychotic and you're in 0% engaged in reality, that means that you need help from an outside source to be functional. So that's not the same thing as someone who has reality testing, who has self-agency, but you also have a severe mental illness like borderline personality disorder, PTSD, OCD, whatever it is, where you can, with agency, do something different despite how bad you feel. So there is a difference, but to be clear, it is not being empathetic and compassionate to encourage people to keep being shitty to themselves and other people because they have a mental illness. I've never once had a patient with major depressive disorder who I said, yes, keep talking to yourself that way. That is such a good idea because you poor thing, you're mentally ill. Of course, treat yourself like shit. Like, no, that's a terrible idea. Never, ever, ever encourage that behavior. But clerk therapists will be like, it's okay. We're just going to work on this coping skill right now. So thank you, David P. Robbins, for talking about the difference between acute care and outpatient care. Because people who are acutely mentally ill need drastic support and intervention compared to people who are at the outpatient level of care. And it's easy to scapegoat. It's easy to create a straw man that there is no such thing as mental illness because these people just go to therapy and whine about their childhoods. And that's just not reality. Mental illness is a spectrum. of more or less severe. It's a spectrum of more or less maladaptive. It's a spectrum of more or less self-agency, reality testing. It's all these spectra that are part of mental illness. And so when people talk in overly simplistic ways, you should basically just ignore them because they're charlatans. That would be my advice to everyone. So thank you, David. Really appreciate you. Let's talk about Nick Tabor again, our buddy Nick. So I want to go back to this. I want to, keep this conversation rolling because Nick's post that I'm about to discuss with you, I think, is perfectly in alignment with what I was just saying. So let's talk about this. So, and this is not like a one and done conversation. This will be a theme that comes up over and over and over again. So on November 10th, a couple of weeks ago, and let me just retweet this right now. Okay. So here's what he said on November 10th. He said, the idea that psychotherapy is this incredible advent of modernity really doesn't hold up. It fails to consider the destructive potential in someone bringing their subjective interpretations filtered through all their own unfinished business to your vulnerability. It can be valuable for some people, don't get me wrong, but the typical story likely way overstates its value and understates the risks and harm. So, I want to keep this as the last topic for today's podcast because it's a good one, it's a big one, and it's worth starting the conversation today and seeing how it goes. Because maybe it'll be one and done, but I don't think it will be. So I want to walk through this line by line because each line has a lot packed into it. So the first thing he said was the idea that psychotherapy is this incredible advent of modernity really doesn't hold up. So, is psychotherapy some miracle creation in modernity since Freud or Jean Charcot first hypnotized people? He's saying no, it doesn't really hold up, right? So is it incredible that you can just talk to people and they can feel better? No, that's about as ordinary and garden variety as it should be. I was literally talking to my old man about this on a podcast last week. Like, it's so terrible, in my opinion, that ordinary people have forgotten that one of the ways that we stay sane is by having ordinary relationships with people and trying to be healthy together. So all human beings have these core fundamental existential needs like belongingness, like feeling a part of. So how practically does one achieve belongingness? We achieve belongingness by hanging out together and talking to each other and relating to each other about the good stuff, the bad stuff, and everything in between. That's why I'm so grateful for all of you who are here chatting, because this is part of the belongingness thing. We're talking to each other. We're talking with each other. So is psychotherapy a miracle because we've learned how to talk to each other strategically to help each other? No, that's bullshit. Humans have been helping each other by talking to each other strategically for years. Empathic listening is not special or unique to therapy. It's really not. What's special to therapy is doing it in an organized way, in a strategic way, with specific skills and specific insights. But even that is not super unique or mind-blowing. Good psychotherapy is not rocket science. But being a good therapist is very, very hard because it means really being aware of your shit. And that is not a fun thing to do. Taking a look at yourself, your biases, your countertransference, your lack of knowledge, whatever it is, your differences of opinion, your cultural issues, your own personal stuff. All these things, keeping all of this in the back of your mind while you're talking to someone with the intent of understanding them and helping them understand themselves is extremely complicated. But doing it, listening, is not super hard. Reflective listening is not super hard. Motivational interviewing, not rocket science. Getting good at it takes a lot of practice and self-awareness. And the self-awareness piece, that's the hard part. So it's not some miracle. I agree with Nick. He said, and I quote, "It fails to consider the destructive potential in someone bringing their subjective interpretations, in parentheses, filtered through all their own unfinished business, to your vulnerability." So patients do one of the most vulnerable things possible. They talk openly and honestly, hopefully, sometimes, about all the things that they feel vulnerable about: their shame, their sadness, the disgusting things they've done, the sad things they've done, their grief, their hopes, their dreams. People talk about these things with you as a professional. And then, as he rightfully said, our reactions as therapists are, in parentheses, filtered through all our own unfinished business. And I want to spend just a second on this because it needs to be repeated over and over and over again. Dear consumers of psychiatry, dear consumers of psychotherapy, coaching, counseling, whatever you're doing professionally, please hear this loud and clear. The professional you're sitting across from is not special. The professional that you're sitting across from is a regular person. The professional that you're sitting across from is a regular person who has their own baggage. The professional that you're sitting across from is a regular person with their own baggage, which is probably to some significant degree not resolved. So the professional that you're sitting across from is a regular person who has their own baggage, which is to some degree not resolved. And those three things are true about every person doing therapy, myself included. I cannot wait to no longer do therapy. I'll get there. I have a couple of practical things to work out. But genuinely speaking, people who do therapy for a living are not special. They're regular people. They have lots of baggage, maybe more than the average person, and it's not fully resolved. In fact, for most people, it's never going to be fully resolved while they keep doing therapy. So please be real. Please be clear that your therapist can hurt you with their subjectivity. Your therapist can hurt you by being ignorant to their own biases. Your therapist can hurt you by being just misinformed because they believe in some pseudoscience. So many therapists still believe in the Myers-Briggs, which is absolute garbage from top to bottom psychometrically. It's the worst. It's not the worst, but it's up there with astrology. It's not real. So there's so many ways that a clinician can harm you by being ignorant about what the research actually says is true about human suffering and human psychology. They can harm you by being unaware of their biases. They can harm you by being unaware of their countertransference. Or they can harm you by being lazy. And there's a lot of lazy therapists. They're clerk therapists, which we just talked about earlier at the beginning of this podcast. So please, everyone, be clear that there are many people who do psychotherapy, who do psychiatry, who are not special. They're regular people. Even if they're smart, there's a lot of smart people who do therapy, but they're still regular people, which means they're still capable of harming you with their mediocrity. They're still capable of harming you with their ignorance. They're still capable of harming you with their ignorance about something related to the science of psychotherapy. They're still ignorant of their own issues, which keep them from connecting with you honestly. Many therapists have the desire to look good. Many therapists are very agreeable people. Many therapists are more narcissistically oriented than they actually realize. And so because of many of these things that they're ignorant to, they might mistreat you. They might misunderstand you. Now, just because they're mediocre or just because they're unaware, it doesn't mean they can't help you. They might still help you. But if you're out there and you're looking for a professional, you can always ask some simple questions to see how healthy they are and how aware they are. So for instance, if you're out there interviewing potential therapists, you can ask them questions like, how did you work through your own issues? For instance. And if they evade you, run screaming. Or, for instance, they might need to ask, or you might need to ask them, like, what, for instance, is your approach to transference and countertransference? See what they say. See how they respond. because they might have a good response or they might not have a good response. Um, Career Flex says, well, well, damn it, if the Myers-Briggs is nonsense, which is better, the Big Five is way better. The Big Five has better predictive validity, construct validity, test, retest reliability. It's a much better text or test. We'll talk about it offline at some point. So Nick Tabor is correct that there's some destructive potential to therapy, and people are being harmed all the time, and they're not fully aware of it. They're somewhat aware of it because they don't feel understood, or they don't feel like they're getting anywhere, or they don't feel better in a way that's meaningful. And so be clear that like you should demand as much professionalism, you should demand as much honesty from your therapist as possible. And the more evasive they are, the more that person's a charlatan. He says it can be valuable for some people. Don't get me wrong. But the typical story likely way overestimates its value and understates the risks or harm. There's a lot of people that I would call the worried well who go to therapy because they really need someone to listen to them. And they are capable of making changes without therapists. They're capable of letting time and nature do its thing, and they will get better and life will get better. And they go to therapy, they spend money because they want special attention. And then they're afraid to get those needs met with their family and their friends, their spouse, their colleagues, etc. And probably the harms outweigh the benefits for those worried well for sure. Oh, yes. Jonathan says the therapists that harm people are often the therapists who believe that they or their ideas are the thing that's performing the healing. When in reality, it's the patient that's the one who's doing the healing. It's the patient's willingness to have a relationship. It's the patient's willingness to try a new idea on, right? Even if we take the most simple coping skill that you learn in like cognitive behavioral therapy, which is reframing. So reframing is on the more shallow or superficial side of things if you're a psychodynamic person, but it's a great skill. I use it all the time with people across various types of settings, including my supervisees. And so sometimes reframing is called perspective taking. There's various types of ways it's described, but reframing is a phenomenal skill because it's a skill that you can choose to do or choose not to do. It's not something you can easily be coerced into doing. So reframing goes like this. You have an unhelpful reaction or thought that makes you feel bad or is maladaptive. And then your job as a clinician is to help them practice the skill of reframing. Can we look at this from a different perspective, right? Can we look at it from 4 different perspectives, for instance? And reframing itself doesn't fix the core negative belief or even change the intermediate thought or whatever in CBT. It just helps the patient achieve 2 simple goals. It helps them achieve a sense of self-agency. I can do something different when I feel this way, when I feel bad. But also it gives them the power of seeing that their first thought isn't the only thought. So there's cognitive flexibility in the ACT world. And so cognitive flexibility and metacognition are 2 universal goods in psychotherapy land, the world's worst theme park. Therapy land, the world's worst theme park. And so here's what I would say is that the reframing isn't some magical skill. Some people use it and it helps. Some people use it and it does nothing, right? Some people aren't very motivated to change. And so the reality is the person that's doing the healing is the patient. Dear consumers of therapy and psychiatry, it's not the coping skill. It's not the tool. It's not the diaphragmatic breathing. It's not the magical, profound insight your psychoanalyst gave you or some interpretation about their transference or whatever. The thing that's doing the healing is you, the patient, being brave enough to take the risk of trying to live and think differently. And that requires all sorts of respect and admiration because people who are drastically suffering have very good reasons to not think or live differently. We get stuck in the sunk cost fallacy when we're severely depressed or struggling severely with PTSD or addiction. So why change? Because it's always going to be miserable. And it takes all sorts of strength and bravery to try new things when you're suffering miserably, when you wish you were dead. Those are very difficult things. And so if you're not a narcissist, you recognize that the patient is the one doing the healing. They're the one with the knowledge of what they're willing to try and what motivates them. It's not us as the outside professionals. We're not that smart. We're not that insightful. It's on them, right? So thank you, Jonathan, for saying that, because it's an important thing to keep in mind. And so just to wrap this all up in a bow of sorts, please be on the lookout for Clerk therapists. Please take extra good care of yourselves. If you or someone you know is struggling with a serious mental health problem, please help them get the care they need. Please help them find the best possible clinician or psychiatrist or counselor possible, which means someone who's not a clerk, which means someone who's not full of their own stuff, someone who's not an arrogant piece of crap, someone who believes that healing is hard and complicated and it's on the patient. It's not on you, the professional. Like, it's really hard to find good people, but they're out there. So please don't give up hope. And if you ever need anything, you can always find me on Twitter. My handle is at Alobha Patrick, A-L-O-B-H-A, Alobha Patrick. And that is this week's episode of UnShrink Me. Thank you so much for everyone coming out to chat. So many cool people here. Phil, Darren, CareerFlex, Jake, Jonathan, all these people. Thank you all for being here. It's been a pleasure chatting with you and talking with you. There's so much fun to be had in the future. So many cool episodes coming out ahead. And I'm very grateful that I even get to do this in the first place, because there's so many things that could keep me from doing this, and I'm lucky enough to actually be here doing this. So thank you all for coming out every week and chatting with me, because it really makes my life better that I get to share these ideas. We get to talk about them and parry and thrust and figure it out. And it's a real privilege to be here. And so if you found this helpful at all, I hope that whatever you found helpful, you share it with someone. I hope that you can please like, share, and subscribe. CareerFlex says, are you going to fix your cat tower? No, she really likes it all beat up. I should probably get a new one or something, or get some carpet and just redo it myself. But anyways, again, please like, share, and subscribe. Find me on YouTube every Saturday in the afternoon, usually 2 o'clock or 3 o'clock Pacific Standard Time. This week was 3:30. Sorry about that. And it does look rough. My cat tree looks very beat up, and it definitely needs some more carpet for sure. Anyways, as always, I like to end my podcast with a joke. And so without further delay, here is this week's joke. So I was talking with one of my colleagues, one of my very respected longtime friend colleagues, and we were talking about one of his patients. And he was like, I'm working with this guy. I think he's kind of narcissistically organized. I was like, was he narcissistically organized, or is he a narcissist? And I said, which one is it? And he looked at me and he was like, well, I actually think he's actually a real narcissist. And I said, you know what? The great thing about narcissists is they're great. There's nothing to do. He's like, no, he's so hard to talk to because he's grandiose and all these things. It's like, listen, narcissism is super simple. So long as you recognize that they're great, everything gets easy. He's like, isn't that enabling? I'm like, well, have you tried the opposite? He's like, no. I said, okay. I said, the next time you see this guy, just praise everything that he does and validate everything he does and let me know how it goes. And he's like, a week later, texted me, he's like, wow, we had a great session. I was like, yeah, so this praising thing, building what we call an idealizing transference, worked really well. I'm like, yeah, absolutely. And I said to him, this is why it's awesome to work with narcissists, because they're great and everything is great. And so, what's the worst part about working with a narcissist? Nothing. Everything's great. All right. I'll see you all next week. Please take extra good care of yourselves. Please have fun, laugh, eat good food, have good sex, have good friends, have good fellowship, do everything that's good for your mental health. And I will see you next week. Hopefully, Lord willing, hasta